Welcome back to the Deep Dive. Today we're tackling a really important area, neurocognitive disorders or NCDs. We've got some great source material here really focusing on how these conditions are defined, classified, and importantly, how they're managed.
Yeah, our goal today is really to map this out quickly for you. We want to help you see the clear lines between, say, a sudden confusion crisis and those conditions that involve a much slower progressive decline.
Okay.
And hopefully you'll walk away knowing the key signs to look out for, what needs immediate attention, and what signals that sort of gradual loss of independence.
Right. So let's start with the core definition. What exactly is an NCD? We're talking about significant problems with things like memory, judgment, orientation, intellect.
Exactly. But the crucial part, and the sources stress this, is that these aren't just, normal aging or developmental issues.
No.
These disturbances are caused by actual documented physiological changes in the brain. We're talking function, structure, chemistry. It's a physical thing.
A real change in the brain itself.
Okay.
And it's a big category, so how do we break it down?
Well, the material immediately gives us three main buckets, which is really helpful for sorting things out. First, there's the acute, often reversible state, delirium.
Okay.
Then you have the two progressive ones, mild neurocognitive disorders and major neurocognitive disorders.
Got it. So delirium, mild NCD, major NCD. Let's dive into delirium first.
Yeah, let's do that.
This is described as the acute confusion state. And you said recognizing it fast is critical.
Absolutely critical. The sources hammer this home. It usually comes on quickly. And here's the key. It's often reversible if you catch the underlying cause early.
So not something you just wait and see about.
Definitely not. It's a serious medical event. Think medical emergency.
Wow. Okay. So what are the hallmarks? How does it look clinically?
Well, the biggest giveaway is the onset. It's abrupt,
Abrupt how?
like hours to days, not weeks or months. And the core symptom, based on the DSM-5 criteria, is a real disturbance in attention and awareness. They just can't focus or shift their attention like they normally would.
And I read something interesting here. The severity can change a lot during the day. Fluctuates.
That's right, fluctuates. Massively sometimes. Someone might seem perfectly clear in the morning, and then by the afternoon, they're completely unable to follow a simple conversation.
Why is that fluctuation so important for diagnosis?
Because it strongly suggests an acute process is happening. It's not like Alzheimer's, for example, where the decline is usually pretty steady, maybe slowly progressive.
Right.
This fluctuation points towards something sudden, an infection, a medication reaction, maybe an injury, and importantly, someone can have an underlying major NCD and still develop delirium on top of it.
Okay.
You're looking for that new sudden change.
Okay. And there's a tool to help confirm it quickly, the CAM method.
Yes, the confusion assessment method, second. It's widely used, especially in hospitals. It looks for 4 features.
And you need a specific combination.
Exactly. You need both feature A and feature B, plus you need either feature C or feature D.
Okay, let's break that down. Feature A is?
That's the acute onset and fluctuating course we just talked about, the sudden change and the up and down severity.
Got it. And feature B?
B is inattention, difficulty focusing, easily distracted, can't keep track of what's being said.
Right. So you need both of those. And then either C or D. What are they?
C is disorganized thinking. Their speech might be rambling, illogical, jumping between unrelated topics.
Okay.
And D is altered level of consciousness. This isn't just about being confused, it's about their overall level of alertness. Are they hyper alert, jumpy, or are they lethargic, drowsy, even stuporous?
So if you see that sudden onset, the inattention and either the disorganized thinking or the altered consciousness.
Bingo, you're almost certainly looking at delirium, and it's time to act fast to find the cause.
So finding that cause is key because it's often reversible. What are the common culprits we should be thinking about?
Well, about 2/3 of cases have a serious underlying medical issue. Could be an infection like a UTI or pneumonia. Could be metabolic problems, dehydration.
Okay.
But often, the immediate trigger can be medications, especially anticholinergics, benzodiazepines, opioids, even some stimulants.
Wow, common medications.
Yeah. And don't forget substance intoxication or, importantly, withdrawal. Someone stopping alcohol or certain drugs abruptly can trigger delirium.
So the treatment really hinges on finding that specific underlying cause.
Absolutely. You treat the infection, stop the offending drug, correct the metabolic issue, and the delirium often resolves. That's the crucial difference from the other NCDs.
Okay, that's delirium, the acute emergency.
Yeah.
Let's shift now to that other side of the coin, the progressive decline.
Yeah.
The DSM-5 calls these mild and major NCDs now, instead of just dementia.
That's right. It's a helpful shift because dementia became a bit of a catch-all, and this new terminology emphasizes the spectrum of decline.
So let's start with mild NCD. What does that look like?
Mild NCD involves a moderate cognitive decline. It's noticeable, often to the person themselves or their family.
But not devastating yet.
Not yet interfering significantly with independence. They might struggle to recall recent events, have that frustrating tip of the tongue feeling finding words.
Yeah.
Maybe tasks take longer.
So they might start relying more on lists, reminders, maybe need a bit more effort for things they used to do easily.
Exactly. You might see more reliance on notes, calendars, maybe even some subtle personality changes, like being less attuned to social cues. But crucially, they can still manage their day-to-day life independently.
Okay, so that's the key difference then when we move to major NCD, independence.
That is the absolute dividing line. With mild NCD, they adapt and cope, maybe with aids. With major NCD, the cognitive decline is significant enough that it interferes with their ability to live independently.
So they need help with things they used to handle alone.
Yes. Significant difficulty with familiar tasks. Maybe they can no longer manage finances or driving becomes unsafe. They might get easily overwhelmed by too much going on, repeat themselves frequently, need constant reorientation.
That sounds much more severe.
It is. And in really severe cases, you might see major issues with judgment, social behavior, like inappropriate dress or grooming, and sometimes, unfortunately, a real lack of awareness about safety risks. Their executive functions are significantly impaired.
It's moved from needing reminders to needing actual help planning and doing.
Precisely.
The sources also mention these A impairments to help categorize the specific cognitive losses. Can we touch on those?
Yeah, they're a useful shorthand for the types of functions that can be affected. There's amnesia, which is memory loss, obviously. Then aphasia, which is trouble with language, either expressing themselves or understanding others.
Okay.
Apraxia is a tricky one. It's difficulty with motor planning. Like, they have the physical ability to button a shirt, but they can't coordinate the sequence of movements to actually do it.
So it's not muscle weakness, it's the brain's instruction manual that's faulty.
Exactly. Then there's agnosia, which is the inability to recognize familiar things, objects, faces, sounds, even though their senses are working fine.
Wow. And the last couple.
Problems with abstract thinking, which is part of executive function planning, problem-solving judgment, and related to that, apathy, which is a real loss of motivation and initiative.
And you can see how problems with abstract thinking and apathy would directly impact that ability to live independently in major NCD.
Absolutely. It all ties together.
Okay, so we have the spectrum from mild to major NCD. Now let's talk about the specific types of major NCD. Alzheimer's is the big one, right?
It really is. Accounts for, somewhere between 50 and 70% of all cases of major NCD. Huge number.
And Alzheimer's, or AD, typically presents how?
It's usually got this insidious onset, very gradual, and then a slow, steady, irreversible progression. Often over about 10 years, though it varies.
And what's actually happening in the brain, the plaques and tangles.
That's the classic pathology, yes. Amyloid plaques build up between nerve cells and tau tangles form inside them, disrupting communication and eventually leading to cell death. It's like gumming up the works.
And it's strongly linked to age.
Very strongly. The risk just climbs dramatically as people get older. By age 90, some studies suggest the prevalence could be as high as 40%.
That's staggering. Are there effective treatments?
We have medications, yes. Cholinesterase inhibitors, drugs like donepezil, rivastigmine, galantamine, and NMDA antagonists like memantine. But it's really important to understand these aren't cures.
What do they do then?
They can help manage symptoms, maybe slow the progression slightly for some people for a limited time by helping nerve cell communication. But they don't stop or reverse the underlying disease process. They're palliative.
Okay, so AD is the slow, gradual decline. What about vascular dementia, VD? That sounds different.
It is different. The key differentiator for VD is often the progression. Instead of that smooth downhill slope of AD, VD often progresses in abrupt steps.
Steps, like sudden worsening.
Yeah. A person might be stable for a while, then have a sudden decline in function, often related to a cerebrovascular event like a small stroke, maybe one they weren't even aware of, then stable again, then another drop.
A stepwise decline. And symptom-wise. Is memory loss always the first thing?
Not necessarily. With VD, problems with judgment, decision-making, planning those executive functions can often be more prominent early on compared to AD, where memory often goes first. It's directly linked to damage to the brain's blood vessels.
Makes sense. Damage leads to functional loss in steps.
Yeah.
Okay, and the third main type mentioned is Lewy body disease, LBD. What's distinctive there?
LBD has some really unique features. One is fluctuating cognition, similar to delirium actually, but chronic. People can have dramatic swings in attention and alertness from day to day or even hour to hour.
Fluctuations again. And hallucinations.
Yes, often very prominent, well-formed, detailed visual hallucinations. People might see animals or people who aren't there, and they can be very vivid.
That must be incredibly distressing.
It certainly can be. And the third core feature is Parkinsonism motor symptoms like tremors, stiffness, slow movement.
But Parkinson's disease can also cause dementia later on. How do you tell LBD apart?
It comes down to timing. This is
Yeah.
crucial. For LBD, the cognitive symptoms have to start before or, at the very latest, within 1 year of the onset of the motor symptoms.
1 year rule.
Exactly. If significant Parkinson's motor symptoms are present for more than a year before the cognitive decline starts, it's usually considered Parkinson's disease dementia, not LBD.
Got it. That timing is key. Okay, we've covered delirium, the mild major spectrum, and the big three, AD, VD, and LBD. Let's talk about managing these conditions, especially major NCD. The sources really emphasize a broad, holistic approach.
Absolutely. It has to be holistic. We're not just treating the cognitive symptoms. It's about ongoing assessment, yes, but so much focus is on patient safety and managing the environment.
Safety, like preventing falls, managing wandering.
Definitely. Those are huge concerns. But also creating an environment that reduces confusion and distress.
What does that involve?
Things like reducing clutter and excessive noise, ensuring good, consistent lighting, using clear visual cues like signs on doors, maybe high contrast colors to help with navigation, keeping routines predictable.
Making the world easier to navigate when cognition is impaired.
Exactly. And trying to understand the reason behind challenging behaviors. Is the person in pain? Are they scared? Dehydrated? Is there an underlying infection causing a delirium on top of the NCD? Addressing the root cause is key.
Communication's also a big challenge, especially as language difficulties, aphasia, progress.
Huge challenge. Strategies involve using short, simple sentences, making sure you have their attention before you speak, using nonverbal cues, being patient, reducing distractions during conversations.
It sounds like it requires a lot of skill and patience from caregivers.
Immense skill and patience. And that brings us to a critical point the sources highlight. You have to assess and support the caregiver.
The impact on the family.
It's enormous. Caregiver role strain is incredibly common. Burnout, depression, isolation, financial stress. It's vital to recognize this and provide support.
What kind of support?
Education about the disease, resources for managing behaviors, connections to support groups, arranging respite care so they can get a break.
Respite care seems crucial.
I can be a lifesaver. And making referrals to other services, maybe Meals on Wheels, physical or occupational therapy for the patient, adult day programs, you're supporting the whole system.
It's truly team-based care.
Yeah.
Before we wrap up, one more cause mentioned was traumatic brain injury, TBI.
Right. Just important to note that TBI can cause both mild and major NCD. The key is there needs to be a documented history of the brain injury, like loss of consciousness, post-traumatic amnesia, and cognitive symptoms have to persist beyond that immediate post-injury period. It's not just the acute concussion symptom.
Got it. Persistent decline linked to the injury.
Mm.
Okay, this has been incredibly helpful for mapping out this complex area. We've really clarified that urgent distinction between delirium, the medical emergency, and the progressive decline seen in mild and especially major NCDs. And we've highlighted the unique signs that help differentiate Alzheimer's, vascular dementia, and Lewy body disease.
And maybe one final thought to leave people with. We focused a lot on the conditions themselves, but the source materials also list several key risk factors. Things like risk factors for cerebrovascular disease, high blood pressure, high cholesterol, diabetes, also recurrent major depressive disorder, obesity, history of head injury. These are important because some might be modifiable.
Right, so things like managing blood pressure, staying active, managing weight, could that actually make a difference?
Well, the link between vascular health and brain health is incredibly strong. What's bad for your heart is generally bad for your brain. There's a lot of research suggesting that managing those vascular risk factors proactively might be one of the best things you can do to potentially lower your risk or maybe even slow the progression of some types of cognitive decline.
That's a really powerful takeaway, something actionable.
It is. I definitely encourage you to look into what the research says about those modifiable versus non-modifiable risk factors. It's an evolving field.
Excellent point to end on. A reminder that brain health is something we can potentially influence throughout life. Thank you so much for walking us through all of this.
My pleasure.
And thank you for joining us for this deep dive. We'll see you next time.